Hi everybody, we're back. We got Kate and we got Aspen. We kind of switched roles today. Anyway, we're going to talk about ribs. Ribs is something that I get a lot of questions about. People seem to think that ribs are really tough, and they can be. But if you boil it down to its lowest form, it's actually pretty easy. So it's just a matter of learning the steps. So projections, we're going to do an AP or a PA. This depends on the injury site, and we'll talk about that during positioning. We'll do an oblique, and we'll do some lower ribs. Most people, you can't get all ribs on one view. So SID is 40 inches. If your provider wants a chest x-ray, if your patient has some shortness of breath or anything like that, you'll always do a PA chest and then your rib views. But just for a normal person that's just got some painful ribs, we're just going to do a unilateral rib. So central ray is in between the jugular notch and the xiphoid process for your AP and for your oblique as well. Your lowers is at the level of the xiphoid process. Collimation, you need to include rib number 1 superiorly. Inferiorly, you need to get the 12th rib on there. Laterally, just skin margins, and then just the other side of the sternum on the AP as well. Technical factors, we're going to shoot them a little bit lower kVp because we want more contrast. We're looking at a bone. So we're going to shoot those 66 to 68 kVp and 20 to 40 mass depending on the size of the patient. You need to find out where the patient's hurting. Mark the general area with a BB, which I will show you. And every clinic has a little package of BBs and some tape. Okay. This will help the radiologist or provider make a proper reading because they know where the injury is. It's easier because there's a lot of area to look at. Injured areas are always closest to the image receptor. Upper ribs are taken at full inspiration, where lower ribs are taken at full expiration. Okay. Yeah, let's do some positioning. We've got Aspen today. It's the perfect time doing positioning. Okay, so we are going to pretend that Aspen has some right posterior rib pain. Okay, so we're going to have her kind of tell us where she hurts. She can kind of touch what level on herself, and we can bring it back and put the BB. So we're going to say she's hurting right here. Okay, so we're actually going to put it on the lateral side. Okay, at the area that they're hurting. You don't want to put it back here or up front because then it's going to be in the way. So you want it off to the lateral side at the level that they're hurting. Okay, so if she's got posterior pain, we are going to shoot AP. We want her painful area to be closest to the image receptor. Okay, so if she had anterior pain, we would actually shoot this PA and have her anterior side closest to the image receptor. Okay, but for today's video, she's got posterior pain, so we're doing AP. Okay. All right, maybe scoot this way. So like I said, if they do have some shortness of breath, we're going to do a PA chest, which we'll do at 72 inches. And then the rest of our rib pictures are done at 40 inches. Okay, so we are going to have 1.5 to 2 inches of light above the shoulder. Okay, our central ray is going to be in between the jugular notch and the xiphoid process. Okay, the xiphoid process is that little bony prominence at the bottom of your sternum. Okay, and then the jugular notch is the hole we've got in our throat right there. Just make sure you have some light above the shoulder. Okay, and we're going to open it all the way this way, so we'll catch as many ribs as we can on the first picture. Okay, our central ray also is going to be in between the sternum and the lateral border of the chest wall. We want to include the other side of the sternum if we can, and we definitely want to include the skin margin over here. Okay, so we've got our patient marked with the BB. Our central ray is midway between the sternum and the lateral chest wall, and we've got 1.5 or 2 inches of light above the shoulder. Okay, now where this is an upper rib, we're going to do it on full inspiration. So we're going to have the patient take a deep breath in and hold it. Okay, and we'll take the picture. And then, as what I like to do, is I'll look at my image, make sure it's okay, and then I'll come in here and we're gonna oblique our patient, okay, 45 degrees. Now for the AP, or posterior pain, we're gonna oblique him towards the image receptor, okay? That's gonna take her ribs right here and they're gonna elongate so we can see the axillary ribs a little bit better, okay? So same setup, we've got light above the shoulder, we've got light over here on the side, and we're able to see the other side of her sternum as well, okay? Now that's your oblique. Now, say she had anterior pain, go ahead and turn towards there, okay? Is what we're gonna do the opposite on this time, okay? So for a PA, you wanna pull away from the image receptor. Remember that, PA, pull away, right? It's just the opposite of AP. We want this, the affected area, which is up front, up here, away from the image receptor. If we were to shoot it the other way, it would constrict those ribs and we wouldn't be able to see near as much. Just remember, if it's a PA, we're gonna pull the patient away and shoot the away side. Does that make sense to everybody? It's kind of confusing, okay? But on a PA, we're obliquing away, okay? Same 45 degrees, same setup, everything. And then on an AP for posterior pain, just like that, we are putting the patient closer to the IR for the oblique, okay? I don't know how better to explain that. It's something you're gonna need to practice and it's gonna confuse you a few times, but that's okay. Just remember, PA, pull away. If you're shooting a PA, pull that patient away from the IR and shoot the away side, okay? All right, so now we've got our oblique done. We're actually gonna shoot a lower. On some people, you can get everything on one picture, and that's great. That's the best case scenario. If you got a little old lady in here, a little old dude or a kid, you're gonna get all of them on one, okay? But sometimes you can't. So what we do is we'll come over here, we'll move our tube down to about the point of the xiphoid process, which is right there. Okay, go down a little bit more. Okay, and we're going to concentrate on this side again. We can actually collimate down a little bit because we've already got all this. We just want to make sure that we're getting the lower ribs right here. Make sure that you have light at the lower ribs. You can palpate a person's lower ribs right there. Be careful if they're hurting right there. Most of the time you can see the rib cage. So we just know if we center the xiphoid process, we're going to get plenty of the lower ribs. Okay, just don't over collimate and cut stuff off. Just remember we already have this, right? Okay, so our central ray is going to be the xiphoid process centered on the mid right lung. So we're going to get a little bit on the other side of that sternum and our lateral chest wall, okay? And that's our lowers. And we will do an AP or a PA lowers. Some docs like an oblique of the lowers. Sometimes I do, it just depends on where they're hurting. If they're hurting in their lower ribs, yes, do an oblique of the lower ribs, if that makes sense. If you get the entire chest on two pictures with your AP or your PA and your fracture is up higher, don't worry about doing an oblique of the lowers. Okay, always do a PA or AP of the lowers, but the oblique, the only time I do those is if it's an area of interest, okay? All right, but that's ribs, guys. So just, it has everything to do with where they're hurting. If they're hurting up front, we're gonna do a PA. And then on the oblique, we're gonna pull them away and shoot the away side. Okay, if we have posterior pain, we're gonna put their back against there. We're gonna shoot a straight AP, and then we're gonna turn them towards the image receptor. That's just gonna, if you think about it, it's gonna elongate the ribs, allow us to see the axillary ribs a little bit better, okay? Just so you know about ribs, when you're shooting ribs on an older person, like the other day I shot a set of ribs on a 90-year-old, and sometimes it's tough to get good contrast. Just know that it's not you most of the time. Most of the time it's because they don't have any bone content. Okay, just do the best that you can. Skinny winnies and kids, you're gonna get awesome ribs and they're gonna look really cool, especially if you use the lower KVP setting, okay? And I've got written up here, pull away for the PA, and AP, you just put it at the IR, okay? But remember, PA, pull away. It's really important because if you shoot your PA wrong, your ribs are going to be about that long. It's not going to look right, okay? So study your ribs, get in the book, look at how they're done, look at this video, and good luck. Practice ribs. Ribs are cool, okay? If you can diagnose a broken rib on a 90-year-old, you're doing really well, which she did have a broken rib. I felt bad for her. Anyway, today's questions, what do we do for a PA? What did I say? If for a PA oblique, what do we do with the patient? And what side do we shoot? Do we shoot the side closest to the image receptor on a PA oblique or furthest away? Okay, I hope everybody gets some use out of this. Ribs are a hot topic, so yeah, get in there and practice and do them. If you have questions, call me and we'll get through it. So anyway, thanks for being here today. I'll see you